Hi, my name is Hannah Hollenbeck, and this is my final presentation. For my topic, I highlighted the intersection between aging, Asian and Pacific Islander ethnicity, and cardiovascular disease. Specific characteristic traits create diversity and unique circumstances for each individual as they age. This course focused on how overlapping experiences will lead individuals in a certain direction due to the interactions of their experiences. Therefore, in the work and research I highlighted for this overlapping, um, it showed that as adults age, the varying life experiences accumulate depending on their identity and the social groupings they dwell within. Each individual's experience with aging is completely unique due to the intersections that occur. Within my research, I found that Asian and Pacific Islander Americans make up 1.5% of the United States senior population, according to a census done in 1990. Fortunately, this percentage is predicted to increase up to 8% of the population within this century. Those included within this population are those with ethnicity from including the Chinese, Japanese, Filipino, Korean, Asian Indian, Vietnamese, Cambodian, Laotian, Hmong, Thai, Pakistani, Indonesian, Native Hawaiian, Samoan, Guamanian, and Tongan. Unfortunately, all of these intensely different people groups are combined together under the title of Asian and Pacific Islander. When we're looking at this big grouping, fortunately, in the big picture, the Asian and Pacific Islander ethnicity has an overall lower death rate than white Americans. However, chronic disease is still present. And although the overall death rate may be lower for Asian Pacific Islanders in comparison to the white non-Hispanic whites, that does not mean that disease is not present. In regards to cardiovascular disease, it has been found that cardiovascular disease is most prevalent in first or second generation immigrants. And this is believed to be due to the interaction of a new diet and lifestyle in the United States. When we're looking at this and knowing that the first and second generation immigrants are developing these diseases, it's also important to remember that disease can become hereditary and therefore pass on to next generations. It's also important to remember that this is prevalent for these immigrants coming into the United States because of their lack of social support an uprooted familial system once entering into the United States and can contribute to this negative health effect and cardiovascular disease in particular. One other study that I focused on highlighted atherosclerotic cardiovascular disease and the risk factors for developing cardiovascular disease includes diabetes, hypertension, smoking, and dyslipidemia. If you look at this table on the left here, it displays how the Chinese, Japanese, Filipino, and Korean United States elders were more likely to have these underlying health diseases, and in turn, all of these lead to an increased risk of cardiovascular disease in comparison to the white American. One slightly different study that I focused on in my research was a correlative study assessing women with breast cancer and their increased risk for cardiovascular disease. It was found in this study that Native Hawaiian women have a greater risk of cardiovascular related death following a previous diagnosis of breast cancer in comparison to non-Hispanic white counterparts. Similarly, out of all non-US born women, Asian and Pacific Islander women who were born in the United States had the greatest risk of cardiovascular mortality following a diagnosis of breast cancer. The facilitator that is believed to link these two was, like I mentioned earlier, the acculturation process, including diet and lifestyle, and even more specifically, dietary fat consumption and physical activity levels. In my research, I was also able to determine the most prevalent barriers to accessing care for older adults who are of Asian and Pacific Islander descent. One of these was cross-cultural communication, and this was the communication occurring between healthcare agencies and the older adults being limited due to second language use in the work field. Health disparity between varying ethnicities creates barriers and are oftentimes hard to differentiate between, especially with that long list of groupings that I gave you earlier. This leads to a barrier involving sample sizes and adequate research. Oftentimes, results in these studies are too small of sample sizes to generate productive health guidelines that can be used in the future. This ethnogeriatric study that I looked at displayed how specific differentiations among ethnic elders and their health risks have to be executed precisely in order for a study to be used progressively. I also learned in this study that hypertension development was at an increased risk for people with Filipino and Pacific Islander descent, leading to an overall increased risk of developing congestive heart failure. In the same way that, as I mentioned earlier, the interaction between diabetes and an increased risk of heart disease in older adults is prevalent within Japanese, Filipino, Chinese, Korean, Pacific Islander, and Southeast Asian descent. And that's that table that I just put up here on the left side. You can see in the third column underneath Asian and Pacific Islander, the areas most prevalent for increased risk were hypertension, myocardial infarction, diabetes. So how can we address these inequalities? In order to specifically meet these older adults and their unique adversity and vulnerabilities, specific agencies and tactics must be utilized. One particular agency that I researched was Asian and Pacific Islander American Health Forum, APIAHF, and their relationship with the NYU Center for the Study of Asian American Health, CSAAH. In order to find productive methods of aiding aging adults, they studied Asian and Pacific Islander descent and cardiovascular disease. The program they developed and facilitated through community-based organizations was called STRIVE, Strategies to Reach and Implement the Vision of Health Equity. The implementations that STRIVE designed and used as intervention included an increase in accessibility to nutritional foods through neighborhood gardens, farmers markets, and an increase in promotion of nutrition policy. Also, STRIVE encouraged an increase in access to physical activity opportunities. This was done through policy within the workplace, explicit placement of walking trails, as well as an increased relationship between schools and community for facility use. Through each intervention, it was concluded that multiple layer interventions were required in order to effectively aid each quality of the community. A little bit closer to home and more specific for me is this agency here, Hui no Keola Pono. This means living well. Within this program, there is a heavy emphasis placed on older adults and their ability to manage their chronic conditions as they age. This 6-week program equips older adults in management of chronic conditions such as high blood pressure, cancer, being overweight, diabetes, stroke, asthma, heart disease, and arthritis. The main intention of the Ke'olopono group is to allow individuals to feel less limited or held back by the conditions they have to live with. There are 5 basic skills that are learned in this 6-week program: effective communication with doctors, relaxation techniques to deal with symptoms and stress, action plan development, problem-solving skills, and symptom management. Overall, Ke'olopono aims to equip older adults of Asian and Pacific Islander ethnicity in overcoming the limitations and giving them skills necessary to live within their cardiovascular disease. In conclusion, the prevalence of cardiovascular disease and risk of developing cardiovascular disease is heavily apparent within the Asian and Pacific Islander community. Although cultural, language, socioeconomic, and physical barriers may be present, intervention methods have been established specifically to aid these adults. But it must be emphasized that evidence of diagnosis and treatment must be specific to each community and specific ethnicity amongst the high variation that occurs within this larger pool of Asian and Pacific Islander ethnicity. Similarly, regular information check-ins must be conducted in order to administer up-to-date care as cultural competence and assimilation occurs as ethnicities have been in the United States longer. In the end, the aging Asian and Pacific Islander population varies immensely, and determining specific cardiovascular disease intervention must first begin with an improvement in policy and communication efforts with their communities, allowing the older adults to communicate effectively with healthcare providers and get the help that they need and deserve. Thank you for listening to my presentation.